Welcome, everybody, to SimpleMD, the podcast. I'm your host, Dr. Ariel Soffer, and our co-host, Richie. And today we're going to take some of these topics that are swirling around the internet, and we're going to try and make them simple and enjoyable. So sit back and relax. And don't forget to subscribe if you like, and tell all your friends about it. Like us on Facebook, and send us in your questions if you have some. So let's jump right into things today. We're going to talk about, on today's podcast, we're going to talk about three segments. One's going to be about everything about blood clots, as that's really an interesting topic right now. We're going to talk about quick tips for living longer. Some very interesting things that have come up recently. And we're going to talk about celebrities with migraines. There's been a lot of talk about that recently as well. So that's going to be the topics of today, and let's jump right in.
Okay, you mentioned blood clots. Let's get right into it. What are the different types of blood clots that we should be aware of?
Great. So there's really two types of blood clots. There are blood clots on the venous side, so the deoxygenated side, the sort of after the muscles have used the blood and heading back to the lungs for another breath of oxygen and to be redistributed through the heart. And then there's the arterial blood clots, which are the oxygenated red blood that can kind of flow to all the tissues, the brain, the organs, and so forth, with fresh oxygenated blood. Both of those sides can have a clot or a ball, a barrier that can cause all sorts of trouble.
Which type of blood clot is more dangerous?
Geez, more dangerous, I don't know that one can be more dangerous. They're all very dangerous, but the DVT is the most common blood clot we talk about on the venous side, and an example on the arterial side could be the clot that causes, say, a stroke.
Okay, so what is a DVT?
What is a DVT? So a DVT, the actual word means deep vein thrombosis. Deep vein thrombosis means not the outside veins that maybe you see or you may cut or whatever. It's the deeper veins. And those deep veins, particularly in the legs, have a direct track to the heart and can, in the lungs, and they can, if they thrombose, if blood clots go there, they can kill you. So deep vein thrombosis is the beginning of trouble, and it usually starts in the leg. That's usually where we see them. Doesn't have to be, but that's the most common area where we see a deep vein thrombosis. There's almost 1 million people a year that have them, and about 100,000 people die of them every year. So it's, we're seeing the numbers with, like we've never seen before, hundreds of thousands of people dying from corona, but almost 100,000 every year die from DVT.
What are the symptoms? What can we look for to figure out if we have one of these?
So symptoms are unfortunately pretty variable, but let's talk about the ones that we see commonly. So a little bit of swelling, a little bit of redness, maybe some heat sensation, feels a little hot around your leg. Sometimes real tenderness, like if you touch it, you kind of recoil. But about half the people with DVT don't really pay much attention to that, and some don't even have any of that. So it's not one of those things that is everybody has a symptom all the time. But when you do have the symptoms, don't ignore it. If you've got one leg that feels, red or hot or uncomfortable, particularly in the back of the calf, certainly in the thigh where it's even more dangerous. So DVT in the lower part of the leg, like about around the calf, isn't really as dangerous usually as that is in the thigh. So if you've got some like swelling and tenderness in the thigh, bigger problem.
What can it lead to? What are we worried about here?
Well, the most dreaded complication of a DVT, and that's a great question, because it can lead to all sorts of stuff, right? But the most dreaded complication is the pulmonary embolism. What does that mean? Clot in the lungs. What does that mean? You're breathing, air's coming in, but it's not going into your bloodstream. So it's as if you're suffocating. And that's one of the things we saw a lot with corona, and we've seen it with we see it with a lot of things actually, but that's the dreaded complication, the pulmonary embolism. That's the thing that can kill you. If it's big enough, it can kill you immediately. If it's small, it can kill you over time, or it can just ruin your lungs. So I'm not trying to scare anybody, but if you have these signs, you can actually treat it. So treatable. We can treat it in a number of different ways. So the pulmonary embolism is the problem. If you feel like you're getting short of breath, which would be the way that you know if you're having a pulmonary embolism, shortness of breath, and you have a risk for a DVT, or you might have a DVT, man, that you got to get 911 care right away, because we can actually stop it.
What causes it?
Anything that really damages the inside of the vein can cause it. So surgery, an immune issue that the body kind of fights, sometimes your circulatory system, an injury to the leg, particularly if you become immobile, anything that really makes your blood flow sort of sludgy, so anytime it's not moving. I think I mentioned this to you in another topic we were talking about. If you took a bunch of blood and you put it in your hand, you would expect it to clump up, right? So that's anything that does that. So people that are sedentary, sometimes even just general obesity, people that have an injury that causes them to be immobilized, or certain genetic things. There's certain people that have like clotting disorders, women that are on estrogen, or even around pregnancy, causes your blood to kind of clump up. So these are the things that kind of cause a DVT.
Who's likely to get a DVT?
So, right. So, listen, anybody can get a DVT, but obviously, a patient that just had surgery and is like laid up in bed and the blood isn't moving in their leg, and, maybe they feel a little bit of that. They feel a little tenderness in their leg. They may have had surgery on their gallbladder. It may have nothing to do with their leg. In fact, in the hospitals, we very frequently put these anti-DVT boots on and stuff, So, obviously, if they're a little bit older, they're at higher risk. If they smoke more, they're at higher risk. Obviously, if they're more overweight, there's more blood flow that has to go through all the stomach area. And so, there's this thought that causes the blood to sort of coagulate a bit more. Those that are in jobs and situations that they're not moving their legs a lot. So there's a lot of people who have lots of risks. Obviously, if you have a bunch of those risk factors, you're in much greater danger. And of course, cancer. So I don't really want to get too far into that, because there's some types of cancer that actually put you at much higher risk for DVT. So those are the kind of risk factors that are out there.
What's an anti-DVT boot?
Anti-DVT boot is, have you ever had, Rich, like any kind of orthopedic surgery? Or
I haven't had surgery.
So if you have surgery, they use these particular type of, they're called compression devices. And what they do is, when you're laying down or unable to move for extended period of times, instead of just having the blood coagulate like it would in your hand, it actually moves it and mimics the calf movement. Okay. So those are like some of the boots that I'm talking about.
Are pregnant women more likely to get it?
Pregnant women are part of it. So, it seems to be a bit of a combination in pregnant women. So it's not just when they're pregnant, it's also after pregnancy itself, up to a couple of months after pregnancy. That may have to do with the estrogen. It may have to do with the mobility, or the immobility, really. It may have to do with the sort of blood flow trying to go through all of that increased blood flow in and around, the uterus. But yeah, so pregnant women are at increased risk, and post-pregnancy, there's a period of time where you have to be extra careful.
We're talking about pregnancy. What about birth control pills? Can that add any risk to people on birth control pills?
By people, I think you mean women.
Hopefully.
So yeah, I think that women that take hormone therapy in particular are at increased risk. Whether it's birth control is a known risk factor, and there, obviously there are some birth control pills that are more risky than others. So the amount of estrogen and progesterone, and everybody needs to talk to their doctors about what's best for them and have that conversation when they go on birth control. But there's also the postmenopausal symptoms that raise the amount of estrogen in a woman's blood, leads to birth control pills, and that can then lead to increasing the odds of getting DVT. So yeah, hormones do play a big role, and hormones they're very it's a very intricate balance. So playing with them almost in any way, whether it's birth control when you're pregnant, postmenopausal replacement therapy, super cautious and needs to be you need to be at increased awareness that those can put you at increased risk for DVT.
You talked about being immobile can lead to DVT. What about traveling? What about sitting on a plane, sitting on a train? How quickly can these things develop?
Well, so the timing is a little bit different. Obviously, if you have genetic predisposition for it, and there's some like real familial things. We, have lots of patients have this factor V and antithrombin 3. There are these sort of specific terms for genetic characteristics, genes that cause you and people in your family to be at increased risk for clotting disorders. That aside, the rule of thumb is, sort of if you're going to be not moving your legs comfortably for more than 4 hours, so that's why we usually get really more concerned about folks that are taking transcontinental trips than say if you're flying from, Virginia to Boston or whatever, you're less likely to have an issue. But I will tell you that you've probably flown recently, I know I have, where you get stuck on a tarmac and you may have like a 45-minute flight, but because you're stuck on a tarmac, you can't get up. You're unable to move, even if you're supposed to move every 45 minutes. Sometimes they won't let you do it in a taxiway or give you a hard time. So anybody who's going to be moving for a few hours, the rule of thumb is 3 to 4, but with a genetic predisposition it could be less. Whenever you're not going to be moving naturally and sitting in a way that might make it a little riskier. So if you're able to kick your legs up like you would maybe in first class, hey, they don't call it economy syndrome, is what we call it without a reason. It's when you're sort of sitting and the legs are sort of at a 90 degree or similar angle. Those are the risky times for DVT. The way to go about it, go around it, I should say, is to walk around every 45 minutes, or you can, just tap your legs as if there's like a little teeter-totter, and just move your calf muscles physically.
It's like a seesaw.
Like a seesaw, yeah, seesaw. Movement would be great. You're simulating walking, and if you're walking, you're not at risk for a DVT.
So move your legs while you're doing, or get up.
There's two ways that it's almost impossible to get a DVT. If you're walking, or if you're lying flat. So it's kind of you would think that maybe DVT, someone who's like laying down, would have a big risk for DVT. They actually don't have that big of a risk because gravitationally, blood's kind of flowing towards your heart. It's when you're not walking and blood flow is put kind of more vertical, where it's trying to flow, but it can't flow because it's got to work against gravity and some angles. That's when you're at highest risk.
How do you guys diagnose this? How do doctors diagnose DVT?
So, obviously a good physical exam, trying to get the symptoms, having experience, seeing a lot. But the money shot, if you will, is the ultrasound. So an ultrasound machine, which have gotten smaller and smaller, and they're available in most doctors' offices right now. They're like, we call it pathognomonic. You can just see it. You can really just see it. It's very, very difficult to miss. I shouldn't say difficult to miss, but it's easy to do a good job of finding a DVT with a experienced ultrasonographer and the doctor that's going over that. So that's the real shot. You don't really need a CAT scan. You can see it in a CAT scan. You can see it in an MRI. You can see it with other testing. But that little ultrasound machine, like they do for babies, like you see for the heart a lot, the ultrasound is like a really useful way of seeing a DVT.
Obviously, the people that have symptoms are going to show up in your office. You're going to know to give them an ultrasound. The people that don't have symptoms, they can't show up at your place for no reason. But are these guys in the hospital, shortness of breath? Is that what we're talking about?
There are other tests too. So some blood tests are very helpful. There's a thing called D-dimers. It's a really, kind of a great test that we can check with the blood. But if you don't have symptoms, how do you know to get a D-dimer test? Well, we do it sometimes on people that would be at risk. But the asymptomatic person that gets a DVT and then has a bad outcome, is something that we're trying to figure out better, how to find those asymptomatic folks. And a lot of it has to do with risk factor analysis. A lot of it has to do with maybe some better awareness. A lot of it has to do with imaging. So we're learning more about trying to figure out how do you get the asymptomatic person from having a DVT and then having a bad outcome.
How do you treat these?
That's why we're so interested in learning about it, because the treatment, there's so many great ways for treating. So, anything that thins your blood, a DVT is a blood clot, so anything that thins the blood clot is gonna help. Blood clotting is a cascade, so anytime you cut yourself, blood starts flowing, and then it just miraculously stops. How does that happen? How come we don't just bleed out from every cut that we have like a hemophiliac does, right? Because there's it's called a cascade, a blood clot and release cascade, where blood comes, it clots around the area, but it lets everything else around it flow. It's actually pretty miraculous. And one of the harder things for medical students and doctors to learn all of the different movements in and around, and how the body is just so beautifully designed to clot in areas that we're supposed to and keep other areas blood flowing, even though they're just these little sort of cells that have to read a lot of information around it.
What are the side effects of blood thinners, and does that patient have to be on blood thinners the rest of their life once you determine that they have this?
Right. So, blood thinners, there's different types of blood thinners. So the old school blood thinner was called Coumadin, which is really rat poison. It's how we actually kill a rat. You put a bunch of Coumadin, and the rat eats it, and the rat internally has a bleeding problem and dies, right? So it bleeds into itself. It stops its ability. Internal bleeding. So that's how we kill a rat. That little doses of that is how we treated DVTs for many, many, many years, like 100 years, I think it might be, thereabouts. Now we've got a new type of blood thinner that we call the novel. It's not even novel anymore. It should probably be changed. But we have a class of blood thinners that are not rat poison, that work very efficiently. That you don't have to. The problem with the old Coumadin or warfarin is that you had to check your blood. You had to pinch your finger to know where your Coumadin level was, essentially. With these other ones, you just take them once or twice a day, and you don't have to check, because it's very clear how they distribute in the human body, and they've been a great sort of tool in our belt of treating these blood clots. And the side effects are still bleeding, right? So you can still bleed from them. You still have to watch out for minor injuries, because they can become major injuries. In my time, when I was at Cedars-Sinai with all the celebrities there and the guys who were the action heroes, won't get into names, but some of the famous action heroes that had to take blood thinners for things like DVTs had a real issue, because then they couldn't do their own stunts, or they couldn't go skiing, or they couldn't do things that could maybe cause them to hit their head, because if you hit your head and you don't stop from bleeding, it's a closed compartment, and you can have a real problem. It's basically a form of a stroke. So these things have real side effects, and they have to be monitored.
But the new blood thinners have less side effects than the past?
They have less side effects because you don't need to regulate them. One of the problems with the old warfarin was like, okay, I want this guy's blood to be twice as thin as it normally is. Okay, well, you have to give the exact dose, and then you have to check that guy or that gal every few weeks to make sure it's still there. If they ate green leafy vegetables, you may have heard of that. Like your grandma was like, I can't have salad, which my kids sometimes say now. But they couldn't have green leafy vegetables. Had vitamin K in it. Vitamin K is the antidote to warfarin. The Coumadin, the rat poison, and therefore you had to avoid taking too much vitamin K. So, we still have to monitor with the new anticoagulants, but not as much as we did before. And really, you just keep an eye on people. If you see them bleeding too much, their skin becomes, bruisy from just touching it, then maybe you need to adjust.
Is everyone a candidate for blood thinners, or can some people?
Right. So as everybody a candidate, I would say most people are, but if you got a risk, like I said, say you're a skier, you may not be the best candidate. Obviously, those people that you might have a bleeding ulcer, they're a problem if they have some sort of blood clotting problem. They have to watch for things like having black tarry stools. Not to get too graphic, but there are ways to see if you're internally bleeding or if you're having a bleeding problem, and you may not be a candidate for blood thinners.
I was getting to the Vena. Do you want to get to the Vena Cava?
Sure. Vena Cava filters are a mechanical way of having this stop, right? So let's just go through that for a second. So if you got a blood clot in your legs, and the blood clot is going towards your heart, your lungs, and then your heart, or the right side of your heart, which is connected to your lungs, it's intuitive to say, well, let's stop it, right? Well, how do you stop it? One of the older ways of stopping was to have an umbrella that let the blood, it's like a mesh, like what do you call it then when you put spaghetti? A strainer, right? So it's like a strainer, and the blood goes through it, but it'll catch clots, and so we call these things Vena Cava or Vena Cava filters, and we would put them in right by the heart, so in the inferior Vena Cava, which is the bottom, where all the blood flow comes from, the bottom part of the body towards the heart, and it would catch stuff.
Is that a major surgery, or
no? It can be done with via catheter, and it just kind of expands like a stent, essentially, that lets blood flow go through but catches the clots. The problem is, okay, what happens after you catch some clots and now blood flow isn't going through it, and then the body has a hard time getting blood flow to get into it. You're leaving something in a person, and taking it out is not easy. It's not one of those things that we love doing, but it is one of those things that we've done in an extreme situation, and it can stop a dangerous pulmonary emboli, or getting a big clot to your heart.
Do the blood thinning medications, do they get rid of the blood clot itself? Do they break it down?
So yeah, that's a great question. So there's two types. There's the blood clotting medications that we call our clot busters, that actually
attack the clot.
I had a great story of there was a when those clot busters first came out, there was a doctor who was very petrified of having. It was actually one of the guys that invented it, famous guy for me in the medical industry when I was at UCLA at Cedars-Sinai, and he would walk around with a little bit of a clot buster. He said, listen, if I ever really get short of breath, I want you to inject this into me.
It's a little pressure.
A little pressure for a young intern, 25-year-old intern walking around. But he knew that would save his life. And those clot busters became a routine thing that we give. Now, that's a little bit different than the other clot disruptors that we were talking about, the Coumadin and the novel anticoagulants that are out there. They go by names like Xarelto, and you've heard them on television. But those type of things don't lyse the clots. They don't just attack the clots. They just stop the cascade and stop clots from happening. And over time, the body then comes and works the clot free, just like it would do in a scab. You don't want that clot to be there all the time. So over time, the body says, "Okay, job's done," and it'll resorb it. So the clot busters are immediate use; they're in an emergency, and then the Coumadin, warfarin, the Xareltos, they work by disrupting the clot over time, getting rid of it. Now, there is this thing where sometimes someone with a big DVT might have what's called post-thrombotic discomfort. So they may feel this stuff in their legs for long periods of time.
Years. Years?
Well, usually it's within 6 months it goes away. Usually
DVT goes away.
DVT goes away within 6 months. Usually the body resorbs it. You can't even see it a lot of times. Then there's people that you'll always see a little bit of it. And then there's people that maybe it's near a nerve, or for whatever reason, they'll have long-term effects.
Are you confident as a doctor, once you give somebody blood thinners, because you're saying the DVTs could last 6 months.
Right.
Are you concerned about the pulmonary embolism happening while they're on blood thinners, or does that take away that risk?
Very rare.
So once you give them that,
feel much better about it. The risk goes down so significant that I don't. And in fact, when people do have pulmonary emboli, or they have issues, we find those. You do a good history and find out they didn't take their medications for some period of time.
Doc, we talked about in some other podcasts compression stockings. I know you wear them for venous insufficiency. Can that help with DVTs or avoiding getting DVTs?
Yeah. So compression socks, the calf is the second heart. So the calves are designed to squeeze like an ice cream cone, right? So from the little tighter at the bottom, they squeeze upward, they squeeze the blood like ice cream towards the top. And when they're moving, they're great. When they're not moving, they're pretty useless. So what compression socks do is they give that, it's like putting that little wrapper on the ice cream cone to keep it all tight. That's what they do. They add a bit of tightness to the bottom of that ice cream cone and therefore reduce significantly the risk of DVT, particularly in the calf. But all the way up, you can wear one all the way up to your thigh. So compression stockings are absolutely imperative to reduce the risk of DVT. They sell them now at airports. We recommend them for people on long bus rides, and even people that aren't walking around as much. I do it when I'm in my days where I'm not maybe running around a hospital. I like to wear them. I feel better. There's less swelling at the end of a day, and I know I'm decreasing my risk for DVT.
Like with venous insufficiency, would you also recommend elevating your feet? Would that help?
Elevating your feet is also, great. So anytime your feet are elevated, particularly above the level of your heart, you've got almost no risk or very, very low risk of DVT.
You talked about this earlier, but what are the long-term effects of having a DVT?
Well, I mentioned I did run through that a little bit earlier, but that post-thrombotic syndrome, if you have it, you can sometimes have just a little discomfort, and maybe some people see some skin changes and so forth. But if you're on a good anticoagulant, usually there aren't any long-term effects of DVT.
Exercise, I imagine that's great to avoid this, and probably when you have it as well too.
Yeah, we definitely talk about the calf muscle, and that is a key part of it. Moving it, exercising, is an absolute need.
Any travel tips for our listeners if they suffer from this or are afraid of getting DVTs?
Yeah, well, first of all, any long trips, anytime you're going to be in a car, in a plane, in a train for more than 3 or 4 hours, really consider getting a compression sock. They sell them at the pharmacies now. I don't even think you need prescription anymore. You can get even the low levels. They grade them by millimeters of mercury. It's how much pressure, so they can get a 15 to 20. If you don't have any major risk factors, never had one before, just put one of those. They come in all different shapes and sizes, and put one on before you go on the particular trip that you're going to take. Make sure you're well hydrated. Even with them on, try and get up every 45 minutes and walk around, or do that kind of seesaw movement with your legs, just to sort of keep that calf moving. So those are the kind of the basic travel tips that does save lives, because if you keep that in mind, we'll lose a few less people every year from travel.
Okay, we're done talking about the venous side of things. You mentioned earlier the arterial blood clots that can form.
Right.
Can you tell me a little bit about that?
Right. So if we're talking about all blood clots, so we talked about venous blood clots, and I think we covered that pretty well for today. But now we're going to talk about the arterial side, so the red blood. And the type of clots most commonly seen on the arterial side are actually part of the atrium, meaning part of the heart that squeezes down and throws a clot to the body, to the actual organ, not to the lungs, because that was on the venous side. But this is actually to things like your brain, and it can be to your organs, your muscles, and so forth, but the brain being one of the most concerning things, right? So that happens most commonly with a situation called atrial fibrillation. And it's kind of interesting here. So we talked about, like, when I put a little blood in your hand, right? So it's coming from a vein. So it's deoxygenated, it's kind of blue blood, deoxygenated blood. Well, if you take the arterial blood that would like be spurting out, if you hit an artery, you imagine it's red blood, it's just been oxygenated. Imagine that blood also sitting in your hand. So even though it would be maybe a little more red in the sense that it's got oxygen, it's still gonna clump up. So your heart has 2 chambers, really. It's actually got sort of 4, but on the left side of your heart, there's 2 chambers. There's the one that gets the blood after you've breathed oxygen into it, collects it, and then it squeezes down that atria, squeezes the blood into the ventricle that then pushes it to the whole body, and with all that strength, the 120 over 80 millimeters of mercury, all that pressure comes from that squeezing of your heart, right? But it's got a low pressure system in it, that atria that holds it first, gets all the blood from the lungs that's now red and rich, and it squeezes in, and then at almost the same time that the blood is squeezed into the ventricle, then pushes it out to the whole body. Great. That circulation happens 60 times a minute on average in the average person. What happens if that little sac that's supposed to hold the blood just starts quivering? Meaning the blood goes in there, but it's not being squeezed into the ventricle. It'll get there because of the way pressure moves, but it's going to sort of stagnate. It's going to clump a little bit. And the thing that makes that chamber sort of quiver is this thing called atrial fibrillation. It's an electrical problem. It's like a short circuit. And when that happens, and it happens relatively frequently as we get older, when that happens, that's when you can get a little bit of a clot that goes into the ventricle and then goes to the brain. That's a stroke, and that can be death or coma or.
So the AFib can cause the clot. It's not the clot itself. The
right.
AFib is
the AFib causes that sac to quiver, fibrillate. It just kind of quivers, and then blood can kind of clot in there, because if blood isn't moving around, it's going to clot. It wants to move. So if it's quivering in the atrial fibrillation, in that scenario, that electrical malfunction.
The AFib with an irregular heartbeat, but is that the same thing, or is it?
So that is what we call it. We call it the irregular heartbeat. So it's irregularly. It's not something that we can, because sometimes we have an extra heartbeat, or what's called a PVC. It can go ba ba bum. Ba, ba, bum. That's irregular, because normally you want to have ba, 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 right? But if you have ba, ba, bum, that's an irregular beat. But an irregular is ba, 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 ba. It's like a fluttering. I've often heard it described as. So that irregular heartbeat is what we call atrial fibrillation. It has to do with an electrical malfunction, electrical short circuit. That's the most common short circuit that we see as we age.
Well, it's interesting because I never really understood why it mattered if you had that. But is it because that it can cause this slight clotting that can lead to this? Is that why the AFib is such a important thing to deal with for people?
Yes.
No?
I'm not really sure.
Yeah. No, because I never, just off record, I never knew why. Okay, so I got an irregular heartbeat. Am I dying from the irregular heartbeat? It seems like, okay, the way I saw it in my mind was every now and then you have a different beat to your heart. I never understood why that was important, what that led to. But you're saying that AFib can lead to a clot.
Well, what you're feeling, what a lot of people feel when they feel like a bump or they feel is not necessarily atrial fibrillation. That's often what we call an extra heartbeat or a PVC. Those are benign. The difference between a PVC and atrial fibrillation can be a difference between life and death. So atrial fibrillation can kill you. A benign PVC, an extra heartbeat, is absolutely innocuous, doesn't lead to any badness 99.9% of the time. So how do you know the difference between an irregular heartbeat and an irregular heartbeat? Or how do you know the difference between an extra heartbeat and atrial fibrillation? And I got to tell you, you know who's got the best answer for this? Steve Jobs.
Really?
Now, maybe it didn't work out for him from a physical perspective lately, but I will tell you that the Apple Watch mimics a tool that we've been using for years, which is this Holter monitor, or these monitors that we put on people. But the simple Apple Watch is actually why I wear it. If I ever have an extra heartbeat, I just push the EKG function on this thing that I bought or my kids got me to get for $350. I push the button and I can see if I have atrial fibrillation or not. It will tell you if you're at risk for atrial fibrillation. It's the most incredible thing. We have tools that we do it.
You're a doctor. As a lay person, I could tell the difference between AFib and a benign, regular heartbeat.
Yes, with an Apple Watch.
With an Apple Watch.
Isn't that cool? And I've no, they don't know me at Apple. I have nothing to do with the company. This is not plugging them. There are other tools that use this as well. I think, some of the other watches out there that use it, but there's algorithms that are now written so that the software picks up your heart rate and can tell you if it's irregular. It actually does an EKG. And you can actually now send that to your cardiologist for confirmation, but I'm pretty sure you get a good idea. You can be pretty confident in just looking at yourself and going, do I have atrial fibrillation? Now, it doesn't mean if you have atrial fibrillation, you're not going to immediately die. But your atrium is quivering, that sac is quivering, and little clots can form. And over time, it can throw one of those clots, to a bad place in your body, like your brain.
And that was my question. With the AFib doesn't kill you. It's what the AFib causes, which is these little
That's exactly
clots
right.
that can eventually...
It's very rare for AFib to go so fast or be problematic to kill you. It can happen, but it's very rare. Usually you're right. It's the clotting that comes from the AFib that can do all the damage.
And you're a doctor, so you see this on your iWatch, not
Right.
to deal with Apple, but they're not telling you what you have. It's just reading what
It's an EKG. It takes an EKG.
But you have to know what you have to know.
Yeah, I think it can give you an idea if it's atrial fibrillation or not, but certainly a doctor can confirm it, because sometimes the tracing has to be right, and you can send them to your doctor or give it to like an EMT that's nearby or whatever. I've seen it save lives. I've seen people literally use their Apple Watches to figure out whether or not it was AFib or even some other rhythms. But we're talking today about AFib. It's really good in detecting atrial fibrillation. These are algorithms that took them, 10, 15 years to put on a watch. It's not like it just came out with it as like a cool little thing. It's been a long time coming. And there are lots of other tools that are out there that will do that, little tiny devices that you can use to find out if you have atrial fibrillation or not. I don't know how we went on this tangent completely, but certainly you can diagnose it with some of the technologies that are out there today.
Same thing as with DVTs, how to treat?
Blood thinners, same idea. So those novel anticoagulants, similar, we used to use like the old rat poison, the old Coumadin, warfarin. We still kind of do in some cases, but those blood thinners are very useful in helping that quivering atrium not to have clots. So we use them all the time, and they save lives by stopping the clotting from happening.
And the same thing, the newer blood thinners are better than the older ones.
Yeah, they're better for us to control the Eliquises and the Pradoxes and so forth. And there's even some new ones that are coming on the market. But yeah, you only have to take them once or twice a day, and you don't have to pinprick yourself all the time to make sure it's okay. So they're wonderful in reducing stroke in particular.
And this is something that somebody feels when they have this AFib going on. Is it continuous, or is it temporary that it happens? How does that work? And how do you deal with it?
How do you deal with the fast heart rate?
How do you know that? Do you actually feel something? You're going through it? Do you feel your heart racing?
Yeah, people often feel like a fluttering or a palpitation that happens, so usually the magic number is like 100. If your heart rate's above 100 and you're at rest, there's usually a problem. It can be atrial fibrillation, it can be other things as well, and but we have great medications that can slow it down. Number one, so that's one of the first things we want to do for atrial fibrillation is to slow it down. Then you want to reset the irregular heart rhythm. Okay, so you want to turn it back into a regular heart rhythm. There are a lot of ways of doing that. The most famous way is shocking somebody. So we do that relatively commonly. We sedate everybody and we give them a little zap, and it's like a short circuit that just goes back into regular rhythm.
Is that in a doctor's office? Or
yeah, it's in a doctor's office or in a medical setting. Usually it's in a hospital, to be honest with you. So that's something that we do relatively commonly, but we have to also be sure before we do it that we make sure your blood's pretty thin, so we often don't do that emergently unless there's an emergency going on, but it is one of the ways to treat it. So you thin the blood, you can shock it, and then you can give medications to keep everybody in sinus rhythm. So meaning in a regular rhythm, you give medications that promote sinus rhythm. If all of that doesn't work, then you can talk about some mechanical things called like ablation. You can go in there and you can like cauterize the short circuit, like you would do in a wood shop. You use like a high heat or high cold, and you kind of zap the areas that are causing the short circuit.
Once you have it, are you more likely to get it again and again?
Unless you get it treated, and the causes for it, are usually it's a mechanical problem. Usually it's just part of sort of aging, but drinking too much can cause it. Caffeine in excess or even if you've got now a propensity for it, even a little bit of caffeine, over-the-counter cold medications that have ephedrine, things that kind of stimulate your adrenaline, can cause atrial fibrillation to.
What about general overall health, being in shape? If you don't exercise regularly, can that help avoid ever getting it?
Not really. Not that I know of. I'm not saying that a sedentary or someone who's in terrible shape might not have it, but that's not the biggest thing that causes atrial fibrillation.
What does cause it?
So, like I said, obviously, too much alcohol that can cause it. Age, genetics are causes for atrial fibrillation. It's really not a problem of the sedentary. It's more a problem of people that are getting older. Certainly, people that drink too much. It's just a
How common
short
is it?
circuit, like you would think of. The wiring just kind of frays. There are a lot of other more specific reasons, like valve problems and things like that. But you're talking about just general atrial fibrillation. So let's the last thing that we can wrap up on this is sort of pacemakers.
Mm-hmm.
So one of the ultimate treatments for it can be with the pacemakers, and these little pacemakers like the size of a dime these days, and they can be put in if you get to the point where it can't be treated with medications or these minor surgical procedures. So there are these advanced things that you can do, but to keep away from it, you really want to eat a healthy diet, get regular sleep and exercise. Sleep in and of itself has been shown to be a risk factor. People that have sleep apnea have a higher risk for it. Again, I think you need to have an underlying genetic thing, because there's people that have sleep apnea that don't have it. But getting good sleep, avoiding sleep apnea if you can, watching out for too much alcohol or over-the-counter medications, and of course smoking. So those are the lifestyle kind of issues. But today's topic was really just to kind of go over the general idea of clotting on the vena side, clotting on the arterial side. I hope everyone has a better understanding, of that. I'm sure we'll do lots of more, sort of podcasts in the future about each specific one. But we were trying to answer the questions for the viewers of clotting in general. I think we've done a decent job of that today. Hopefully we've helped everybody feel it's a little more simple than they did before listening to the podcast on blood clotting.
You definitely gave a lot of good information, simple information, and cleared some things up in my mind that I thought about for a lot of years. Okay, let's get to the next topic of the day. This is something that I saw on the internet. I thought it was interesting. I know you'll have a different perspective as a physician, so I wanted to bring these up with you. It's 18 secrets for a longer life.
Okay.
Okay, I'm just going to throw them out at you, and you give me your
18's
thoughts.
a great number. 18 in the Jewish religion is Chai. The number is the most spiritual number because it means life. So I like the word 18. 18 secrets for a longer life.
So we're going for longer Chai. Okay,
All
does
right.
that make sense?
Okay.
All right. So the first one's protect your DNA. How do I do that?
Right. Well, DNA. I think there's a shelf life to our DNA, and there's a great study out of this Harvard professor that talks about telomeres and how the ends of the DNA start to sort of shrink, and we don't really know how to make it last, how to make our lives longer and longer. Although there's a lot of study on that, and people say that we are going to be. We do know that if we have unhealthy habits, it shortens our DNA and therefore probably shortens our lifespan. So bottom line, healthy habits may actually slow aging actually at the DNA level.
The next secret is playing to win. It says being conscientious is one of the things that may...
Right. So they found, this long longitudinal study, watching people over about 80 years, that people that pay attention to detail, they sort of think things through. There's this word mindfulness we hear a lot about, actually live longer. Maybe it's because they're making decisions to watch their health. Maybe they have stronger relationships with others, better careers. I'm not sure, but mindfulness, really sort of thinking about everything in your life seems to make you live longer.
I wonder if that's some exercise for the brain or something like that. Next one, jump to making friends. Make friends. This is a tough one for you. Go. What's your thoughts on that?
Maybe dead very soon. Um, Another reason is, making friends. So it's very clear that not only having more friends, but who your friends are and the social ties that go with it are a clear link to longer friends. So not only is it important to be social and to have those social ties that help you feel like you're in touch with others, but it's also the quality of those social ties.
Which brings us to the next secret, which is to choose your friends wisely.
Sure. Well, that's for sure. I mean, we've done study after study that have showed that, like, when obese people hang out with, other people with bad health choices, that they work to worsen their health choices, and quite the opposite. If you hang out with a healthier person, you're more likely to take on some of the habits of those people with healthier lifestyles. So that goes all the way through to smoking, which is an obvious thing. If you hang out with smokers, you're more likely to smoke, and therefore it's a cycle, and so it's a bit contagious, as can be stopping smoking. Can be, if you hang out with people that have just stopped smoking, you're more likely to stop smoking. So these have all been studied and are true.
The next secret is actually quitting smoking, which you brought up.
Right. Well, that's a clear. We can't hammer that enough. But there's this British study that shows that if you stop at any particular decade, it really just adds years to the back of your life. So the earlier you stop, the more years you get to the back end of your life. So there's just no question. If this is about tips to live longer, stop smoking.
I love the next one. It's napping.
Yeah. So, embracing the ability to nap is, it's not something you can do all the time, but I can tell you throughout my life, particularly when it came through all the medical training, the internal, the internships and residencies and all the time, being able to sort of declutter your mind and take a nap periodically was key. Obviously, not only do you need to nap, but you need to get, somewhere between 6 and 8 hours a night. And that just becomes clearer and clearer as the studies come in and in. And part of that includes napping. So there's a study that showed that those that took naps were actually less likely to die of even heart disease. So maybe it has to do with the stress hormones that happen if you're sort of tired and irritable and you don't take that nap, and how that acts on the inflammation in the body. So it could be as simple as that, and that's what the study suggests. So, your body tells you what to do, listen to it.
Next one. We've talked about this a lot, the Mediterranean diet.
Oh, yeah. Well, we have podcasts on that, and I'm a huge believer, as you know. But a diet rich in fruits and vegetables and whole grains and legumes and olive oil, extra virgin olive oil and fish is going to simply make you live longer with less disease. And the less disease you have, the more you're going to have a higher quality of life. So that's a whole podcast in and of itself. But yes, Mediterranean diet, you will live longer. Period. And I say that period because there's Lion study, Predimed study, and about 50 studies underneath that, all coming from reputable places showing the Mediterranean diet's the way to go, and all of the major societies, American College of Cardiology, American Heart Association, the Mayo Clinic, everybody sort of is in agreement on that one.
The next one, if you don't want to eat the Mediterranean diet, it says eat like an Okinawan.
Well, it's, if you break down the Okinawan study, there's some similarities to the Mediterranean diet, but it is a little bit different in the sense that they're more sort of focused on green and yellow vegetables and very low calorie. So that Okinawan study really was about calorie restriction. We've found that does help you live a bit longer. Personally, I don't know if I would want to live longer if I had to eat like an Okinawan, but you definitely can live a bit longer, it seems, with less calories. And the Okinawan trick was to eat 80% of what was already a fairly limited diet of, green and yellow vegetables, but you always left 20% on your plate. So if there's one thing you could take from that, leave a bit on your plate. And those Okinawans that didn't follow that diet and ate more of a Western diet lost that age benefit because they were, at that time when they did the study in Japan, they were the longest living people on Earth.
So it's a combination of the quality and the quantity that they're eating?
Yeah.
Do you think that leads to that? Okay. Yep. Next one, it's an advertisement for getting married. It says, get married, and you tend to outlive your single friends.
Look, there's economic support that seems to have with coupling. There's obviously the health backing of a partner. But certainly we go back to the socialization issue, which may not be as easy to do in a single person than a married couple. But it is clear that married people tend to outlive their single friends. So it's important to have a partner, a good partner. That's a whole different discussion.
In your opinion, is it worth it?
Of course it is. My wife is listening, and I want both of us to live long. You want to hear something funny? As we were talking the other day about eulogies. My wife is 7, 8 years younger than me. So we're talking about how important it is to do a eulogy, and I started saying, how I would, listen, I would say some really great things about you. She goes, what are you talking about? I'm eulogizing you. You are never.
Right.
You are, because she's 8 years old and she's very fit and so forth. She was insulted that I would possibly be, even the thought of eulogizing
You're
her.
planning. You're planning ahead. Or you're actually.
Who buries who? Yeah.
Next one, lose weight. That seems obvious, but what are your thoughts on that?
Oh, okay. So. I would tell you, I'm going to go off tangent here for a second, but we had the same conversation with my wife where my favorite Larry David episode, I don't know if you ever saw the one where they were doing the vows, they're going to redo their vows to one another. And so Larry David goes to his wife on the show and says, okay, I'm ready to do it. She says, okay, great. Listen, Larry, this is what you're going to say. You're going to say, honey, I love you, more than, she's saying this to him, I love you more than everything, and you're the world to me, and I want to be with you from now through eternity. And she goes to him, no, you got to say the same thing back to me. And he goes, I can't. She's like, why? She goes, I can say, I love you, don't you love me? Yeah, I love you, and I want to be with you for the rest of my life. Yeah, I want to be with you for the rest of my life. But I kind of saw myself as a single guy in eternity. Right. So marriage is certainly good through life. In eternity, I guess it becomes a different thing. Anyways, I'm sorry. I went on a tangent. Keep going.
No, we're up to the losing weight.
Okay.
Any Larry David episodes on losing weight?
There were actually quite a few, but probably not appropriate for this particular one. But yeah, listen, obviously, being overweight, the biggest problem with being overweight is really diabetes. And we see a lot of heavier folks that don't have diabetes. Some bodies tend to handle it better than others, but once you get diabetes, I think all bets are off. And then you get an inflammatory process and lots of end organ damage, and that's not where you want. So you can hold a little weight, great. But once you get diabetes, and that usually is because you've held weight for too long, then you start having all sorts of dying conditions, whether it's heart disease or the like that will come usually from belly fat, and deflating that spare tire is going to make you live longer.
It seems like a lot of the recurring themes are losing weight and the next tip, which is to keep moving, exercising. What are your thoughts on that?
The magic number is probably about 2.5 hours of moderate exercise per week. I tend to think interval training is the way to do it. So kind of burst, kind of get that heart rate up and let it come down. Get that heart rate up and let it come down. I have this conversation a lot with my patients where they're like, I don't know if I need to run for a long time and keep my heart rate up. And the answer is you really want to train your heart to go up and come down. The more you do that, the lower your resting heart rate will be. So people that do interval training, that do those kind of like sprints, if you will, if you can, doesn't have to be a sprint, it could just be like a brisker walk for a period and then relax. On the treadmill, you go up to 5 and then back to 3. That kind of thing trains your heart in a way to keep your resting heart rate lower. And if your resting heart rate is a bit lower, you're going to live longer. So about 2.5 hours a week of exercise is the way to go in interval training, and break it up, 3, 4, 5 times a week, whatever you can do.
The next one, drink in moderation.
Yeah, it's, the studies are very clear. A little more drinking is better than none. Too much, and you start to die from other ailments, not to mention car crashes and the like of alcoholism, but certainly your liver can only handle so much. But, a couple of drinks a day, a little more for men. So one drink for a woman, 2 drinks for a man is kind of a rule of thumb. Red wine seems to maybe have a little bit more benefit, but we're unclear of that. At the end of the day, we are clear that people that have a moderate amount of alcohol, not a lot, it's a J curve, right? So no alcohol at all, you don't do as well as people with 1 or 2 drinks. 4 or 5 drinks, you start to die earlier from all sorts of other reasons. So get that, that sort of the arm, or whatever you would call it, the dip of that J curve with a little bit of alcohol.
I know drinking affects the liver. It affects the heart as well?
That drinking affects the heart? Yeah, it's beneficial for the heart, it appears.
For the heart. Okay.
For the heart in 1 glass a day for women, 2 probably for men. More than that, it can be actually toxic to the heart.
Next tip, get spiritual.
So, it goes back to sort of this mindfulness and so forth, but it seems to be people who attend religious services of any sort seem to live longer than those that don't. There was this lovely 12-year, so over a decade study, people over the age of 65, and they said that people that sort of went to a religious service about once a week seemed to live a bit longer than their age-matched folks that didn't. Whether it has to do with the immune system or the social network, we're not really sure. But maybe it is more back, it's back to that mindfulness, that conscientiousness, and so forth. Maybe it's just social structure, but that seems to be helpful in living longer.
Next one, forgive.
Well, as we know, chronic anger and keeping things bottled inside leads to anxiety, leads to cortisol release, and all that sort of adrenaline that's out there that does bad things to your body. So if you can forgive, you'll reduce anxiety. If you reduce anxiety, you can reduce cortisol and other bad stress hormones. You'll have better blood pressure, and you'll live longer.
The next one is interesting. Use safety gear.
It's one of the things we know. Hard to get everybody to use it, but helmets, seat belts are really important, particularly in younger folks, because that's those that seem to get into more of the crashes. But seat belts reduce the risk of death by 50% in a car wreck. 50%, 50. I mean, the helmets also huge in bike accidents. So you want to live longer, use those safety equipment.
And the next one you touched upon when we were talking about naps, but it says make sleep a priority.
Yeah, so proper sleep, will reduce not only your general, weight. So if you sleep more, you sleep better, you'll be less overweight. But that in turn then affects obesity, affects heart disease, mood disorders. So, if you're down to 5 hours, 6 even a night, you're probably not going to live as long. So if you get more than that, you're going to live longer. So for a variety of reasons, get proper sleep.
Makes sense. And the last, I think this is the last one. Let me say. No, it's not. To manage stress.
Yeah, same idea. That whole mindfulness. It seems to be. I don't know if you got. Again, back to the iWatches, I get these things always telling me to deep breathe or meditate or whatever it is. It seems like reducing. The brain is wired in such a way that it needs to reduce cortisol. It needs to reduce stress, and I think we have to do that. It doesn't happen naturally for everybody. So managing it seems to be a way of reducing stress, and that causes you to live longer.
Keeping a sense of purpose.
one of the risk factors I've found in my practice is retirement. We see when a person retires, I put a little asterisks on their EMR and tell our folks we got to watch them a little closer, because when people lose their sense of purpose, they can lose some of their habits. When you lose your habits, you can go off the deep end. You don't sleep well or eat well or exercise as much or what have you. And so keeping a sense of purpose and a regimen seems to be one of those things that makes not only people live longer, but possibly use their minds more, and then have reductions in Alzheimer's and so forth. So these studies are pretty clear on having good hobbies if you do retire, having good sense of purpose if you do, and if you don't, you may not enjoy as much life.
18 tips for living longer.
Yep.
Let's go on to the last subject of the day, which is actually celebrities who get migraines, which has been in the news lately. Yep. I actually get migraines occasionally. I get something called cluster headaches, so I'm interested to see who.
What do they feel like for you?
Well, the cluster headaches are weird. They usually don't come during REM sleep. So you go to sleep, you feel fine, you wake up in the middle of the night with a headache, and they'll usually come every day for 2 to 3 weeks, sometimes 4 weeks. When I get them, I don't get them often. I get them. I feel when I'm sedentary, when I really haven't been doing much, maybe not sleeping as much as well, and but I may get them every 4 or 5 years, something like that. But when they come, they're a pain. It's tough to do anything when you have a migraine.
They're brutal, and the purpose of today obviously is not necessarily to go through the different types of migraines. There's so many. It has to do with the way the blood flow in the brain sort of relaxes and clamps down, and but there's been a lot of talk lately. Apparently a lot of celebrities have made the news, so we've gotten a lot of questions on it. But you said you wanted to go through a few of the celebrities, and I can give you my thoughts on a couple of them.
I was just interested. Serena, who many consider the best tennis player ever, she suffers from migraine.
No, I don't know Serena personally, but from what I read, there was there's a menstrual migraine. I believe hers were of those type. It seemed to correlate with hormone levels with her and her menstrual cycle. About 60% of women say that it gets worse with their periods and more likely to happen during those times. So sometimes just tweaking the hormones can be very helpful. So that was what I heard about her.
Ben Affleck gets migraines.
Even though women are much more likely than men, 6%, so it's a 60 and 6% rule. So 6% of men get migraines as well. So a sleep schedule is, I find, one of the most important ways to help men with migraines out and trying to get enough sleep and quality sleep, which sometimes is tough. But Rich, when you had your migraine, how did you deal with it?
I actually, the last time it happened, I kind of fought through it. The last 2 times it's happened. So we're talking about over a decade, maybe 2 or 3 times that it's happened. At the beginning, I went to a doctor, went to a neurologist to make sure everything with the brain was okay. After that, they started giving me migraine medication. Then I can't say it helped that much. What I did the last few times is I just fought through it. I started exercising in the midst of it, exercising, stretching, getting regular sleep. And I found that without medication, I was able to control them. I was also kind of more concerned of what I was eating as well. So I probably ate healthier during those times as well. But I find that the times I get it is when I'm less active. And to get rid of it, I become active. And it's not easy because these things are debilitating. And
yeah, it's everyone sort of does get to figure out what works for them. It's a variable process. Even the same types of migraines are variable in a lot of individuals. So people have to kind of learn what works for them, what doesn't. Some people like really cold, dark rooms, the different triggers. You really do have to think through what works for each individual. I remember reading about Ben Affleck, who had them, I think, when he was doing one of his films. It really did come down similarly just to sleep schedules, and that worked for him. I remember around the same time Lisa Kudrow.
Phoebe?
Phoebe. Yeah. I don't think it was from her cat hair.
Smelly cat?
Smelly cat hair. Um, if I remember reading about her, I think she had it as a child. And, so children have about a 50% chance of having migraines if one of their parents have it. So there's a strong genetic component, it appears. 75% chance if both parents have it. So knowing your family history can help and diagnose it with younger and younger people.
Marsha Cross from
Desperate
the show
Housewives.
my wife watched a lot, but not me. Desperate Housewives. She gets migraines as well.
Right. There's a lot of medications. I think she had used one of the triptan medicines, so she was one of the earlier users of that, and that is one of the ways. I'll never forget when that medication first came out. I was actually an intern in L.A., and I had an aunt visiting me from out of the country. And
When was that,
heard
about
about it.
1990?
Yeah, it was actually 1990.
Okay.
And I remember getting the injectable version of that medication and injecting her in between like appetizers and dinner of an important family dinner, and it just stopped her migraine completely, and she'd never had that happen before. It was the first time I'd ever injected a family member's. The whole thing was very memorable for me.
Mm-hmm.
But those types of medications, and there's a whole host of them now, are very useful for folks.
You're not alone if you get migraines. Janet Jackson gets them as well.
Right. She suffered from, I think, a type of vestibular migraine, which, the vestibular system is what controls your dizziness, and I think she was sort of famously getting very dizzy. Bright lights and loud sounds really trigger that, and up to 50% of all people that get migraines get really dizzy. They're treated similarly. And you want to also avoid the triggers that can make you have your migraines. So the bright lights and the sounds are often triggers for the vestibular type of migraines that she had.
Another celeb, Kristen Chenoweth. Chenoweth? Is that?
Yeah.
I'm laughing because I'm getting old here, and I don't know her quite as well as the other ones.
Right. I've seen her obviously a bunch. She was well known for having the botulism toxin called botulinum, but it's botulism, and it's a poison, but it seems to, like with Botox, work very well for migraines. So over the last decade, we've used Botox basically to inject into people to reduce their migraines. It has a lot to do with that, the vasodilation and the vasoconstriction. They are the way the arteries and veins kind of open and close and blood flow to the head. And so that seems to have been one of the things that she was well known for using for her personally.
More my age, Carly Simon.
She is, first of all, I think my favorite singer. But she was known for having it as well, and I think she's a person that became kind of a teetotaler, so she stopped having alcohol. But red wine has been a real big trigger for a lot of folks, and they don't know if it was the stuff in the red part of the wine or wine in general, but wine is a common trigger for a lot of people, including Carly Simon.
Cindy McCain.
Yeah. It's funny. I remember when she was saying it was like she said that the migraine was like torture. Didn't John McCain actually go through torture when he was in Vietnam?
Be careful using that around him.
Right. He must have been like, yeah, that's maybe not the same thing, honey, but it was really terrible for her. I remember she talked about it during the presidential campaign, and it was the bright lights that were thrust upon her at the time that actually triggered it for her.
Literally the bright lights.
Literally the bright lights. She actually started wearing sunglasses, and that can be useful for people to avoid the migraine triggers. So people know what triggers for them, and find different types of avoidance behaviors.
The next celebrity is Troy Aikman, which you would think he suffered from concussions during his career, but he actually got headaches when he was a kid, before the football.
Well, you wonder, was it before the football? I mean, he was probably playing football at the time. Wasn't he a
that's
baseball
true.
player too? I don't know if he got hit, but at the end of the day, a lot of the people that have had head injuries are at increased risk for migraines. So I don't know if he was one of those. Certainly quarterbacks take hits, and it is a concern, and why we're trying to avoid concussions as well, because that can be one of those side effects.
Elle McPherson.
Yeah. So Elle was married to Jeff Soffer, who's not related but shares the same name as me. We see around the communities here. And Elle was one of those that was well known for using acupuncture and some of the holistic techniques that reduced stress and probably dilated up her, brain circulation, and did help her a lot. So acupuncture and things like more holistic methods seem to also be very helpful.
Similar, I guess, to Troy Aikman, Denver Bronco Terrell Davis, the running back for the Broncos from the late 90s. He suffers from headaches as well.
Do you remember that Super Bowl scenario?
I do remember him having a good Super Bowl. I don't remember that he left the game with a migraine, though. I've some of the guys I do. I remember Scottie Pippen leaving a game, missing, but I don't remember Terrell Davis missing a game, but apparently he did.
I don't only remember it, but I remember hearing that he got medication. And, they're so strict in the NFL on like what medications you can and cannot take. But I think he went, I don't know if it was a halftime or the quarter or sometime he got medication. I don't know what the medication was, but it cured his migraine. He went on to do great things. So finding out what works for you, what's the medication or the technique that works for you, is the way to live with migraines. Because we really have to live with them. They're very, very, very infrequently just cured.
Another athlete, Kareem Abdul-Jabbar, he gets headaches. He gets migraine headaches as well.
Yeah. Well, he's also sort of famous for his, embracement of all the sort of Chinese arts in particular. And, I think from him, he described it as something to do with the neck and the way that maybe his muscles were pulling on things. So I think he used also some of the holistic techniques.
It's interesting with my headaches. Mm-hmm. One thing I would do when I felt one coming on, I would literally stretch my neck for about 5 to 10 minutes. Just do all these different stretching, and often the migraine wouldn't come.
So listen, I think we can wrap up here. I think at the end of the day, celebrities are people, and they sort of exemplify what's going on. I think what we've gone through today is to show that there's so many different ways. You have to know what your triggers are, know what helps you, be open-minded to holistic and traditional and even novel or new techniques that we have, which include new medications and new methods. Migraines are something that probably aren't going to be cured, but they can be really well managed. And certainly we'll do more of these podcasts about the different types of migraines and what may be sort of cutting edge, and try and make it simple for everybody so that they have a good resource to sort of keep in touch with with medicine and all of the ways of treating ailments. So I think we're going to wrap up for today. I wanted to thank Richie and all of our listeners and viewers for another successful podcast of SimpleMD, where we take today's complicated medical knowledge and try and make it simple for everybody, and have a great conversation, and take your potential questions. Please submit them to info@SimpleMD. Subscribe, tell your friends about it, like us on Facebook, and we look forward to seeing you next week at SimpleMD, the podcast. Thanks so much.